Turning Point, the cardiac rehab program. And I am looking forward to, after I run through these slides, if there's any questions that we can talk about. I'd love to have a discussion after as well. So for those of you, I think most of you are at Bramhall. I'm not quite sure how many work in the office over at Scarborough, or if you've been to Turning Point at 96 Campus Drive. We have the whole ground floor, the daylight basement, or we like to call it the garden level. And we actually got a remodel done 3 years ago. So we doubled the size of our gym, and it's a really beautiful space. We really love it. We're not using it so much right now during the pandemic, but we have a classroom. We have a classroom that, oh no, I'm echoing. We have a classroom that allows us to have a demo kitchen and group classes that before the pandemic, this classroom was full with patients and their loved ones. This is our multidisciplinary team. So we're made up of exercise physiologists, exercise specialists, nurses, and we have a registered dietitian as well. Jennifer Monty, who you all know, is leaving us, and Lisa Thomas have been our medical directors, and we're really hopeful. I think I'm about 98% sure that I think Dr. Hull is going to be joining us as medical director in a few months. So we're excited about that because we kind of consider him our exercise physiology physician guru. So we're excited about that. And I really want to try to expand doing pets with him and stress testing with him and kind of share staff. So that's sort of my vision with that. But it's a great team. It's like a family. And I know one of the questions that was asked was who is served? So who qualifies? And that can be a big question for cardiac rehab. Unfortunately, it's all insurance driven. So it really depends on what the patient has for insurance. But for the most part, we can take, any heart attack, STEMI or non-STEMI, within 12 months usually of their heart attack. Some wild insurance companies want to have them in within 6 months. And then we can do heart failure. So CMS is very strict on their heart failure enrollment. It has to be chronic stable heart failure with an ejection fraction of 35% or less. They have to be on optimal medical therapy for 6 weeks. So we usually wait 6 weeks before we enroll them. And they cannot have any planned major intervention within 6 months. And some do require having a stress test prior to enrollment. Some, I think it's mostly Anthem, but there are a couple insurance companies that require a stress test post qualifying event pre-enrollment. So that can be a little bit of a holdup as well for enrollment. Some insurance companies will take heart failure, will let us enroll heart failure patients that don't meet that strict criteria. For example, Anthem is pretty lenient with their heart failure. They just say chronic stable heart failure, and they don't specify in their medical policy what the ejection fraction has to be or anything like that. So whatever referrals we get, we end up looking through with a fine-tooth comb to make sure they qualify. And if they don't qualify, I will get into this more, but we have a self-pay program that is not telemetry monitored, and the patients pay a monthly fee, and they basically essentially have the same program, just a little less monitoring. So they would definitely have to be stable for that. in terms of functional capacity and compliant with their medications and things like that. No, if they have, preserved ejection fraction, we would just want to make sure they don't have a high PVC burden, ventricular ectopy, things like that, because we won't be monitoring them. So what we do is if we get a referral that doesn't qualify, we'll work with the primary provider and just make sure that it's okay, that they feel safe, that they're going to be exercising off the monitor before we offer it to the patient. We take LVADs. We have about 4 LVADs enrolled right now. Any stents placed, bypass surgery, valve, TAVRs, mitral clip, heart transplants. We do have a vascular walking program for the vascular rehab patients, PVD patients. And then we also take atrial fibrillation patients into our self-pay program because insurance doesn't qualify. They don't cover AFib alone. And any other, primary prevention patients can join that self-pay program as well that haven't necessarily had a heart event, but have risk factors and could really benefit from cardiac rehab. The only exclusion criteria is if they self-decline because they live over 60 minutes from a cardiac rehab, or if they're being discharged to a long-term care facility, or they have an unstable condition, ongoing medical treatment. We would usually not refer at that time and defer to the primary team to refer when appropriate. So this is a kind of a chaotic slide, but it's what's offered. So yes, we have inpatient cardiac rehab. We call it phase 1. And that is when we try to assess every patient on all the cardiac units to see if they qualify for cardiac rehab. And we assess their risk factors for heart disease, and we fill out a flow sheet on them, and we visit the patient and we discuss their cardiac risk factors and cardiac rehab, and then we send a referral in to their home hospital for phase 2 cardiac rehab. So Maine Med gets about 30% of the referrals that come out of Maine Med, and the rest are spread out through Maine, New Hampshire, and wherever we're getting our patients from. So we also have the outpatient program, which is what I've been talking about, which is phase 2 cardiac rehab. It's immediate outpatient, secondary prevention. So it's typically started as soon as possible after the qualifying event, and insurance will usually cover 36 visits. So that would probably be about 12 weeks if they did 3 days a week. Some patients choose to do 2 days a week and they're here longer. It really depends on where they live and what they can commit to. But most insurance companies are covering 36 visits. And we try to urge them to use them all if possible, because there is a dose-response relationship, which I can get into. We have the vascular rehab program, which I talked about. We have the Next Step program, which is a maintenance program. So after patients graduate the 12-week program, they can join basically a gym membership and pay a small monthly fee to come right now 2 days a week because of the pandemic. And then that prevention service is the other self-pay program that I was talking about. Sort of encompasses all of the medical gym patients that might not qualify for cardiac rehab but need medically supervised exercise. The way you can see our encounters in Epic, if you want to find cardiac rehab documentation, it's all in the media tab because we scan in every session report, but it will show up as an encounter in Epic, and it will also, you'll see it in the notes as well. But if there's ever any concerning session that happens at Turning Point, we usually route it to the primary care team for them to review and follow up with the patient. As far as referrals go, We have all of our referrals go in through Epic. So it's really important where the star is there. The department that you're trying to refer it to is really important. There's probably about 70 referrals in a work queue right now that have no department listed, so they didn't really go anywhere. And I'm working on that with IT and the medical office just to make sure that we're not missing referrals. But it's really important to know where the referral's going and how to get it there. So what happens at cardiac rehab? So this is our passion. So it's individualized treatment plans based on medical needs and goals. So every patient that comes to us has a 90-minute to a 2-hour intake, which is unreal these days. I mean, think about the providers you get 15 minutes. I think maybe APPs you might get longer if you're in the office. But we really have a lot of time to sit with the patient, talk about their goals, talk about their risk factors, do some behavioral health coaching and some motivational interviewing, and figure out what their individualized treatment plan is going to be. And then Medicare requires that we get that treatment plan signed every 30 days, and we update it every 30 days and have it signed by a provider. So it really is pretty intensive. It's medically supervised exercise, monitored exercise, coaching on how to self-progress. So our main goal is that they know how to exercise safely on their own. They know how to self-care and work on their risk factors on their own. It's a lot of education on those risk factors, identifying what they could work on in their lifestyle and how to do that. And we talk about things like keeping a healthy weight, maintaining exercise, heart healthy nutrition. Like I said, we have a dietitian on staff, so we try to have each person have a consult with her, and they can bring a family member in. We're hoping in the future to go back to our group education classes, because that was really nice to have that camaraderie and the learning together as a group. But right now during the pandemic, we have slides going while they're exercising, different topics each week. We do handouts. We give them other resources, like the Cardiac College is a really great educational website, and it's completely free. So we do a lot with education. Another question that was asked is, when do patients usually begin cardiac rehab? And the goal is, the benchmark for quality is trying to get patients in within 21 days of their hospital discharge, regardless of their diagnosis. It's typically 6 weeks for the chronic stable heart failure because of those CMS requirements, where they need to be stable on their medications for 6 weeks. And it's typically 4 to 6 weeks for valves or complex CABGs. But current wait times, because of our pandemic, is at least 4 to 6 weeks. So we have our slam dunk, MI-PCI coming in, they have to wait at least a month to even start cardiac rehab. So it's definitely a big problem, the accessibility right now. A lot of questions on the referral process for cardiac rehab. So before COVID hit, so 2 years ago, we would have our colleagues in the hospital, our exercise specialists, and they would do a chart review on each patient and see who qualifies. And then they would just run in, have a quick discussion with them, refer them to cardiac rehab at their home hospital, and be done with it. Then COVID hit, and we stopped inpatient rounding. We weren't going into the hospital at all. We were doing remote referrals, doing remote chart reviews, and just automatically referring patients to their home hospital and putting a note in their chart saying, you've been referred to cardiac rehab. They'll the facility will contact you and see if you're interested. So it really wasn't ideal. Then we had our lovely redeployment to the hospital for 6 weeks. And we decided to capitalize on that time, and we redesigned our inpatient phase 1 referral process. So now, it's definitely increased the quality of care. And I think the way we're doing it is also going to increase enrollment rates and retention, and outcomes because of the education piece. But so now we have a staff member in the hospital on the cardiac units Monday through Friday, 7 to 3:30. And as most of you know, because I know I cringe, we've been messaging you to put these orders in for us. We have an inpatient consult to cardiac rehab order, the CON 30443, and that order allows us to mobilize and ambulate the patient as appropriate. So we do a lot of chart review, we work with the care team, and if we are able to, we get those patients out for a walk, we mobilize them, we educate them on target heart rate and that rate of perceived exertion, and sort of their blood pressure response, and what we check vitals. So it's a lot more in depth as to what we were doing before. We visit the patient, we educate them on their risk factors, and then we also refer to their phase 2 cardiac rehab at their home hospital. So yes, there has been a little change in the referral process. So this is a slide that I created, a spreadsheet I created for our phase 1 team, but also other facilities that are trying to refer in Epic to cardiac rehab programs. And the top list is all of the main health hospitals that have Epic. So those are internal referrals, and what their department name is. So it has to be sent to that department name in order for it to get into their work queue, and what the referral or procedure code would be to get it there. And Midcoast just joined about a month ago. So they are now on this list, which is wonderful. All of the other hospitals in Maine that have cardiac rehab are listed underneath. And when we refer there, it's outgoing referral, and we end up manually faxing it because they don't have Epic. But I often share this with the practice because a lot of times there's confusion on how to get the referral to the actual department or the actual site that it should go to. Unfortunately, the little box on the right, there's only 3 of us that are open right now in Maine Health. Cardiac rehab, because of the pandemic, they're shutting them down. Hospital leadership is shutting down cardiac rehab and relocating staff as needed. I'm hoping that doesn't happen to us again, but who knows if that will happen. But currently, right now, Southern Maine Healthcare is open, Midcoast is open, and Maine Medical Center is open. So again, you could see how that is also interfering with our wait times and our enrollment. It's quite sad. There's plenty of supporting evidence out there. I'm sure you've seen it. Cardiac rehab is associated with hospital readmission rates declining, 20 to 30% reduction in readmission rates after a year after a cardiac event. Mortality rates are lower, quality of life improves, return to work more quickly. There's a dose response relationship too, they've found. So every visit completed can correlate with a 1% reduction in mortality. So that's where we try to get our patients to complete all the visits that they're approved. Enrollment rates in cardiac rehab are very low nationwide. It can be, 30% or under. And there's been research saying that if cardiac rehab participation rates were improved to at least 70%, that we could possibly prevent 25,000 deaths and 180,000 hospitals each year. So that's pretty remarkable. There's also been some research on early cardiac rehab and the benefits of starting as soon as possible. Study out of the Heart and Lung Journal with heart failure patients, those that attended at least one session within 6 weeks post-discharge had a lot better outcomes than those that either didn't start at all or started after 6 weeks. So we definitely should work to try to improve our enrollment time and enrollment rate. There are some New Hampshire cardiac rehab programs. A snowbird or someone from Massachusetts or wherever, we look up their closest cardiac rehab and we end up referring that way. So there also is a Maine Health Cardiac and Pulmonary Rehab Work Group, and we would love to have an APP champion if anyone's interested. So we meet monthly. All the cardiac rehab groups in Maine Health meet monthly, and we try to unify our policy and our procedure and our resources, which is tough, but we support continuous improvement. We try to collaborate and talk about barriers and work together on how we can improve our programs. As I mentioned, less than 50% enroll in cardiac rehab and about 80% complete. So there's a lot of room to capture more patients and retain them. One big project that we're working on right now and we're currently involved in is virtual cardiac rehab or home-based cardiac rehab. CMS has approved us doing audiovisual cardiac rehab at home for the next 3 years, I believe. So we were lucky enough to secure some philanthropy funding to purchase, it's called the Channel Health Platform, Better Hearts app for patients to use on a mobile device or on a desktop computer, whatever device they currently have, iPad, Android. And it's a dashboard that lets us send education to the patient, chat with the patient, send exercise prescriptions, and then they can log what they're doing at home and we can keep an eye on them. And it's really cool. So we've had that running since October, and right now we have all of our maintenance patients invited to join. And it's really cool to see them logging their blood pressures and their exercise heart rates and things like that. And it shows you which articles they've read, and you can see how activated the patient is. So our goal is to offer this hybrid option to improve participation, because we have an accessibility problem right now. So we're hoping some people can do this cardiac rehab program remotely. And we're hoping that the remote option can start at the bedside. So while we're in the hospital at Maine Med doing rounds, we can sign them up for this, offer this, get them hooked up. It's immediate patient engagement through the mobile app, and that will really help with the continuity of care. They'll have remote access to their rehab team, and it can act kind of as a bridge to get them to when they start their phase 2 cardiac rehab. So we're kind of calling it phase 1.5 cardiac rehab. And then once they're ready to join the phase 2 cardiac rehab, they can do some at home, some in the facility, and it's a lot more flexible. The application has a lot of modules already built in, and then we can also customize it. But they have a cardiac core education, diabetes, heart failure education, phase 1.5, pulmonary, smoking cessation. It's really cool. So our vision for Maine Health cardiac rehab programs, the big one is, as you know, we're working on automatic order sets for that phase 1 order and the referral. I have a ticket in right now that they are working on, the orders team. We're hoping every potential eligible patient is approached with an invitation to the virtual platform during their hospitalization. Enrollment rates improve due to patient identification early and kind of bridging them to their cardiac rehab program. Retention improves because there will be remote and in-person options. We can bill for remote options as long as we have audio-visual capability, and that the sessions are 31 minutes in length. For every eligible patient in Maine Health Service area. So my last slide here is about the automatic order sets. I do have a ticket in, and where it lands now, which I need some help with, is which order sets should this cardiac rehab inpatient consult order be a part of? I'm not aware of all the different order sets that exist. So if someone could help me identify which order sets we could plop this order number in, I think that would save you a lot of time and us a lot of time chasing you down to put this order in for us. And it would be much appreciated. But if anyone has any questions, I'd love to chat more about cardiac rehab, or if I missed anything.
Yeah, we do. Oh, you can hear me. There's an echo. Need this. Sorry, Caitlin, I'm having technical problems too.
That's okay. I'm gonna
Here, can you hear me okay?
yeah, I don't know if it's me. Yeah. Can you hear me? Oh,
Caitlin, can you hear me?
yes. I can. That's much better. I shut. Okay.
Caitlin, can you hear me?
Yes.
Okay, sorry. And then do you guys have, is it one person that's in-house from 7 to 3 to 5 days a week at Maine Medical Center?
Yes. On Fridays, we try to do 2 people to catch people over the weekend.
Okay, so it's basically kind of scanning all the people that qualify, all the patients that qualify, and then also you're technically starting the rehab process, and the order is kind of allowing permission for them to like get up
Yeah.
and move around. Gotcha. Okay.
Which there's been, there's the nursing order, activity order, and we do see to make sure if they have any restrictions and everything. But, this program was sort of designed like within 2 weeks. So it was like, we need an order, we need this, we need that. And working with regulatory affairs, they thought it was a really great idea to keep that APP or the provider putting an order in.
Yeah. Okay. Yeah, I'll help with at least what order set we use, and so we could build it in that template
Great.
for now. And then I don't know if anybody else is interested, but I'd be curious of what kind of information you give the patients as far as nutrition and things of that nature. I get lots of questions, especially after PCI.
Yeah.
And I don't really necessarily want to begin the whole education piece because it's a lot for them to observe or to absorb rather. But I would just be curious of what information that you do give them.
Yeah. So that's a really hard one because, as you know, there's a lot of differing opinions about nutrition.
Yes.
And even a lot of our providers in our system have differing opinions. Like some are very heavy on vegan and the forks over knives, and they'll,
yes.
They will really push that on the patients, not push it, but then they come to us, and our approach is really to meet the patient where they are. So we really approach it at know where their food comes from, try to avoid the processed food, whole, natural, lean. We don't say people need to be vegan. If they're going to be having meat, make sure it's lean and local and they know where it came from. But, the fruits, the vegetables, the whole grains, that type of thing. And then, really trying to meet them where they are though. Like, let's say they eat hot dogs every day. Well, maybe they can move it down to 3 days a week first and, take small steps.
Gotcha.
Small achievable goals first.
Gotcha.
I would be happy too to have our registered dietitian share some information. But we are about to offer another registered dietitian position. And my vision for that is that the cardiology practice can share that individual for consult in the office, but also to try to, be more connected dietary education and also outpatient. So I have a lot of visions for that position that we're trying to hire into.
Yeah, that would be awesome. Okay,
Yeah.
cool. All right, I think that's all my questions. I have this recorded. Anybody else have anything?
I was just wondering, I'm going to be up in the North Conway office and just wondering how we would refer patients to the virtual rehab.
Yeah, so right now, Maine Med is the only one that has the virtual. However, we're working on trying to expand it through the Maine Health system. What we're hoping for is that we can capture them while they're at Maine Med and enroll them while they're a patient of Maine Med, and then keep them until they can do cardiac rehab in North Conway. But when in doubt, you can always send a referral to Turning Point, and we can kind of collaborate with the patient and figure out what works best for them.
Okay, yeah, that's kind of too bad because it seems like the patients who go to Maine Med, like they're closest, like the ones who are in the more rural.
I know.
Even more.
I know. And one of the barriers we're having is, let's say a patient from Phippsburg wants to do virtual cardiac rehab with us. Okay, so if they're exercising at home and they have a medical issue, our emergency protocol would be to send them to Maine Med. We would call 911, but there's a few barriers to work out when they're in different service areas.
That makes sense.
Sure you can. Something like that one? Yep.
Well, thank you very much for your time. And I really appreciate all of you that have been putting those orders in for us. I know you probably cringe when you see our epic messages come in, but we are working on trying to streamline that so it's not so much extra work.
Okay, great. Thank you. I will.
Thank you so much.
All right, take care. Thanks. Bye.
Bye.